Good evening friends, I am Dr. Chaitanya and welcome to my channel Critical Care Basics. So far we have only put ECG lectures in this Critical Care Basics channel, but now most of the topics of ECG have been covered, and now we are delving into another topics as well. We had a patient recently who had thyroid storm, and we had a tough time managing the patient. So I just thought probably I could share some of the inputs on thyroid storm. So let's get started. Thyroid storm is a rare life-threatening condition characterized by severe clinical manifestations of thyrotoxicosis. It is reasonably rare. Only 0.5 to 0.76% patients of hypothyroidism ever land up in this thyroid storm. In US, 16% of patients who were admitted with thyrotoxicosis had thyroid storm. So patients who have thyrotoxicosis and get admitted have significantly higher chance of developing thyroid storm. These are the precipitating factors. The most important factor is abrupt discontinuation of antithyroid drugs and any other acute event like thyroid or non-thyroid surgery, then any trauma or infection, acute iodine load or amiodarone, and parturition. So any stress can cause thyroid storm. Appropriate preoperative preparation of hypothyroid patients undergoing non-thyroid and thyroidectomy surgery has led to a reduced incidence of thyroid storm. This is an angry looking ultrasonography Doppler picture of a patient who was in thyroid storm. See the vascularity of the thyroid. So why does thyroid storm occur? There is a rapid increase in serum thyroid hormone levels, especially free T3-4 and T3 and T4. There is increased responsiveness to catecholamines. These are various hypotheses. Enhanced cellular responses to thyroid hormones. And while the total T3 and T4 levels were similar to those in uncomplicated patients, free T3 and T4 were high. So it is the free T3, T4 levels which matter. The symptoms, the most common, any patient with hypothyroidism will have tachycardia, that is more pronounced in thyroid storm, congestive heart failure, hypotension, cardiac arrhythmia, most commonly atrial fibrillation, and patient can suddenly die due to cardiovascular collapse. And in one series, more than 60% of patients had tachycardia, most commonly AF. The second class of symptoms are related to central nervous system. Patient can have a hyperpyrexia, 104 to 106 degrees Fahrenheit, and agitation, anxiety, delirium, psychosis, stupor and coma are also common. In fact, some consider this to be an essential feature for diagnosis. Otherwise, if these features are absent, the patient may be categorized as having hyperthyroidism rather than thyroid storm. In one series, ultralmentation was the only clinical finding that distinguished storm from so-called compensated hypothyroidism. Lastly, third system that gets involved is the GI system. Patient can have severe nausea, vomiting, or sudden diarrhea, or a feeling of defecation, and patient may also have abdominal pain and hepatic failure or jaundice. These are the markers of mortality. These patients are more likely to die. Patient with older age, more than 60 years. Central nervous system dysfunction, especially seizures and coma. Requirement of mechanical ventilation and non-use of antithyroid drugs or beta blockers. So if timely beta blockers and antithyroid drugs are not given, then there is high likelihood that these patients will succumb. Laboratory findings. All patients with overt primary hypothyroidism, including patients with thyroid storm, have low TSH naturally and high free T4 and T3. There could be mild hyperglycemia secondary to catecholamine induced inhibition of insulin release and increased glycogenolysis. Mild hypercalcemia, abnormal liver function test. Many patients have jaundice and raised enzyme, and there could be leukocytosis or leukopenia. This was a score by Birch and Warshawski, developed in 1993, and they gave points for various clinical symptoms and signs, and if you get a total of more than 45, it is highly suggestive of thyroid storm. If the total is 25 to 44, it supports the diagnosis of thyroid storm, and if the total is less than 25, the diagnosis of thyroid storm is unlikely. They included 4 parameters. One is temperature. So accordingly, if the temperature is 99 to 100, 5 and so on, if the temperature is more, you get more points. Central nervous system, if the patient has mild symptoms like agitation, then the patient gets 10 points. Moderate like delirium psychosis, 20 points, and if the patient has severe coma, then gets 30 points. Similarly, cardiovascular, tachycardia, the heart rate will decide the points. If the patient has heart failure, pedal edema or severe heart failure, then there will be more and more points. Similarly, if there is a precipitant history is positive, then the patient gets 10 points. Lastly, gastrointestinal hepatic dysfunction, if there is moderate like diarrhea, nausea, vomiting, abdominal pain, patient gets 10 points. If there is severe feature in form of unexplained jaundice, the patient gets 20 points. So out of these 4, the points that the patient gets are total, and if the total is more than 45, it is highly suggestive of thyroid storm. This is the most important single slide in the whole lecture. What are the basic treatments of thyroid storm? You start with a beta blocker, unless it is contraindicated, to control symptoms and signs induced by increased adrenergic drive tone. A thionamide to block new hormone synthesis. Iodine solution to block the release of thyroid hormone. Iodinated radiocontrast agent to inhibit peripheral conversion of T4 to T3. Glucocorticoids to reduce the conversion of T4 to T3, promote vasomotor stability, possibly reduce the autoimmune process in Graves' disease, and possibly treat associated relative adrenal insufficiency. And lastly, bile acid sequestrants like cholestyramine to reduce the enterohepatic cycling of thyroid hormones. So we will go in details of each of the points. We start with beta blockers. Begin immediate treatment with a beta blocker, typically non-cardioselective like propranolol, in a dose to achieve adequate control of heart rate. So how much dose is to be given will be decided by the heart rate and the blood pressure. Beta blockers are contraindicated in patients with acute decompensated heart failure. In those patients, the hyperadrenergic state is important for maintaining the cardiac output. In this setting, a beta blocker induced reduction in heart rate could lead to profound hypertension and even cardiac arrest. So first check whether the patient has evidence of heart failure before starting beta blocker. Beta blocker should be used with caution in patients with contraindications like asthma, COPD or peripheral vascular disease. In patients with severe asthma in whom beta blockers might be contraindicated, you can use a calcium channel blocker like diltiazem. So this is how propranolol acts. It stops the conversion of T4 into T3, as well as it stops the peripheral effect of thyroid hormone. Propranolol is used for initial therapy because in high doses it inhibits the conversion of T4 to T3 by inhibiting type 1 deiodinase. The dose of propranolol is started to achieve heart rate and blood pressure. Typically we start with 60 to 80 mg orally every 4 to 6 hours. So this is a very high dose. So please note this dose, 60 to 80 mg every 4 to 6 hours with appropriate adjustment for heart rate and blood pressure. IV administration should be done in a setting where hemodynamics can be monitored. IV dose is 0.5 to 1 mg over 10 minutes, followed by 1 to 2 mg over 10 minutes every few hours. When transitioning from IV to oral treatment, IV therapy may need to be continued until the oral dose is effective after absorption and blood levels. Japanese guidelines recommend the use of short-acting beta blocker like ismolol or propranolol because of its they found that there is increased mortality with patients with heart failure treated with propranolol. Ismolol, the advantages, maybe a reasonable option if it is uncertain that beta blocker will be tolerated or not. If you are uncertain that whether the patient will tolerate beta blocker, then you give ismalol, because it can be immediately discontinued and the effects could be reversed. Recommended published doses include loading dose of 250 to 500 microgram per kilogram, followed by an infusion of 50 to 100 microgram per kilogram per minute. The dose is adjusted based on the heart rate. These regimens permit rapid up and down titration of the drug to achieve adequate beta blockade while minimizing adverse reactions. So it is very short acting, so it can be used as an infusion, and if you think that the BP is dropping, you can immediately stop. After beta blockers, the second drug that you have to give is a thionamide. Begin immediate treatment with either propylthiouracil or methimazole. If methimazole or propylthiouracil is not available, carbimazole is a third drug that is metabolized to methimazole in the body. What do these drugs do? These block the de novo thyroid hormone synthesis within 1 to 2 hours. This is important because they take some time. So if you have to give iodine, it has to be given after 1 to 2 hours. However, they have no effect on the release of preformed thyroid hormone. So the choice of drug, start propylthiouracil for acute treatment. In the European guidelines and in American guidelines, they prefer to use propylthiouracil because it acts faster and it is favored over methimazole because its effect to decrease T4 to T3 conversion. The levels of T3 drop by 45% within 24 hours as compared to only 10 to 15% in 24 hours by methimazole. So it is faster. It is also safe in pregnancy. Patients started on PTO in the ICU should be transitioned to methimazole. Once the patient settles down, then you can shift to methimazole. Why? Because methimazole has longer duration of action, and in long run, it results in more rapid normalization of T3 levels. Frequency of hepatotoxicity is also less with methimazole, so it is relatively safer. Japan, they use methimazole preferentially over propylthiouracil, and they found that the mortality is same with both. The initial dose of propylthiouracil is 200 to 250 milligram every 4 hours. So all the doses are much higher than the normal doses. There is no loading dose. The American Thyroid Association ATA guidelines recommend a loading dose of 500 to 1000 milligrams. The dose of methimazole is 20 milligram orally every 4 to 6 hours. Sometimes you have to use even larger doses than this. So in thyroid storm, maybe you'll have to use 40 milligrams sometimes in place of 20 milligram. So the problem is with thionamides is rarely they cause severe bone marrow toxicity or granulocytosis and hepatotoxicity. So in such patient who require urgent treatment of hyperthyroidism, and if such patient develop these complications or are at a risk of developing these complications, then the only option is thyroidectomy. However, in critically ill patient with history of severe reaction to thionamide and who is too unstable for urgent thyroidectomy, cautious use of alternating drug can be used. 1 or 2 weeks close, and you can use close monitoring for 1 to 2 weeks before the patient goes in for surgery. After beta blocker and thionamide, the third drug that you give is iodine, SSKI potassium iodide or Lugol's iodine. Lugol's iodine is relatively less concentrated or more dilute. So this iodine should be given at least 1 to 2 hours after you give thionamide, so that if the iodine is given before, then this iodine may actually be used for preparation or the synthesis of thyroid hormone. The administration of iodine should be delayed for at least 1 hour after thionamide administration to prevent the iodine from being used as a substrate for new hormone synthesis. When the etiology of thyroid storm is known to be toxic goiter or adenoma or multinodal goiter, iodine should be used cautiously, since the use of iodine can exacerbate hypothyroidism if thionamide treatment is interrupted. So if the thionamide treatment has been interrupted and the patient has Graves' disease or multinodular toxic goiter and you give iodine, then it may actually contribute to further synthesis of thyroid hormone. So you have to be very cautious. So this is what is called as Wolff-Chaikoff effect. When a lot of iodine is given, it gets converted into iodolipid, iodolactone, and it inhibits thyroid peroxidase. So it inhibits the formation of monoiodothyronine or diiodothyronine and formation of T3 and T4. So how do you give iodine? You can give potassium iodide or Lugol's iodine. These solutions can be irritating to the GI tract and should be diluted in 240 ml, that is almost 250 ml of beverage or with food. SSKI, the doses, it is more concentrated, 50 milligram iodide per drop, while Lugol's iodine is 6.25 milligram iodide per drop. So if you give SSKI, you give 5 drops, or Lugol's iodine is 10 drops. There is no standard intravenous iodine preparation, but iodides can be given rectally also. Local esophageal or duodenal mucosal injury has been reported, and after administration of Lugol's iodine. So you have to be cautious of GI side effects as well. If the patient is being planned for urgent surgery, then you start with beta blockers, propranolol in a dose to achieve adequate control of heart rate. So the dose is 60 to 80 milligram every 4 to 6 hours. You also give glucocorticoids to decrease the conversion of T4 to T3. You can use either hydrocortisone or dexamethasone. Bile acid sequestrants, cholestyramine, 4 gram orally 4 times a day to reduce the enterohepatic circulation of thyroid hormones. Iodine, we have already mentioned, either you can give SSKI or Lugol's iodine. Optimum preoperative treatment with iodine is approximately 10 to 14 days. So this Wolff-Chaikoff effect is maximally active in 10 to 14 days. After 14 days, this effect wanes off. So patient can have an escape phenomenon from this effect. So the patient should be operated within 1 to 2 weeks of giving iodide. Glucocorticoids have multiple actions which could help in thyroid storm. They reduce the peripheral conversion of T4 to T3. They may have a direct effect on the underlying autoimmune process, especially if it is due to Graves' disease, and treat potentially associated limited adrenal reserve. So they could actually help to maintain the adrenal reserve. The doses of efcolin 300 milligram loading dose, then 100 milligram IV TDS, or you can also use Decadron. In contrast, we do not routinely use glucocorticoids in patients with moderate to severe but otherwise uncomplicated hyperthyroidism. So if it is thyroid storm, only then we prefer to use steroids. If it is only hyperthyroidism with patient preserved and having no neurological symptoms, you may not use steroids. The data are not in favor of steroids, that they do not reduce the mortality or hospital stay. And glucocorticoid use also increases the sugars, so you have to control sugar with proper insulin use. Cholestyramine, bile acid sequestrant. So thyroid hormones are metabolized in liver, where they are conjugated with glucuronide and sulfate, and the conjugated products are excreted in the bile. So cholestyramine enhances the enterohepatic excretion of thyroxine. The dose is 4 gram orally QID. Can be useful adjunct therapy in patients with thyroid storm, particularly in patients who are intolerant to thienamides. So if the patient are intolerant, or suppose they have agranulocytosis or a problem where hepatotoxicity, when you cannot use thienamides, you can use cholestyramine. Can interfere with absorption of oral medication, so other drugs should be given 2 hours apart, and it can be discontinued when the clinical status improves. After bile acid sequestrants, another drug that you can give is iodinated radiocontrast agents. So these are potent inhibitors of T4 to T3 conversion, and the release of iodine in pharmacological quantities from these agents have additional benefit of blocking thyroid hormone release, synthesis. So iopanic acid and other iodinated radiocontrast agents can be used. They have been extremely useful in treating severe hypothyroidism and in preparing patients for urgent surgery. Dose is 0.5 to 1 gram once daily. Because they are iodinated, they should be given at least 1 hour after thienamide. The last option is plasmapheresis. I was going through the internet for how to treat our patient with thyroid storm, and in one patient, the patient was not tolerating the iodinate thienamide, so patient was very bad, so they took the patient for plasmapheresis, and after that they did a surgery. So it is option for patients who cannot tolerate thienamides and in patients who are being prepared for urgent thyroidectomy. Plasmapheresis removes cytokines, antibodies and thyroid hormones from the plasma. The effects usually last for only 24 to 48 hours. So immediately it should be followed by surgery. Once the patient is settled, iodine therapy can be discontinued unless thyroidectomy is planned in 1 to 2 weeks. Beta blockers can be gradually tapered off and withdrawn when the thyroid function tests normal. Glucocorticoids are tapered and discontinued. PTU, if PTU was given, it should be switched to methimazole. Methimazole is preferred because it has a better safety profile and better compliance rates. Methimazole, the initial dose is 30 to 40 mg daily in divided doses, and dose is titrated down to maintain euthyroidism. Last but not least, it is important to provide patient education about the risk of abruptly discontinuing treatment. So if the patient abruptly discontinues the treatment, there is high likelihood that he'll end up in thyroid storm. So he has to be educated about it. So this is the synopsis of what we have already seen so far. The first drug that you start is beta blocker. It reduces sympathetic hyperactivity, partially blocks peripheral conversion of T4 to T3. We use propranolol, that is non-cardioselective. The second drug is thienamide. Propylthiouracil is preferred, decreases conversion of T4 to T3, blocks synthesis of thyroid hormone. It has a faster onset of action. It is also preferred in pregnancy. Then methimazole, it blocks synthesis of thyroid hormone. So it is relatively safer, less chances of hepatotoxicity. Then after thienamide, you have to give iodine. Inhibits release of stored thyroid hormone, administered only after synthetic pathways have been blocked by PTO or methimazole. And steroids decrease peripheral conversion of T4 to T3, may treat autoimmune processes in Graves' disease, and treats adrenal insufficiency. In this case, we add cholestyramine and radiocontrast agent. Thanks a lot. So this was in short about how we treat a patient with thyroid storm. I hope you are liking these videos. If you are liking, please like, subscribe and share. Bye-bye.